Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent day in Cape Town. It's been beautiful over here, and talking about beauty, we have the advantage of having our old friend and colleague, Dr. Bavi Vythilingum, and she is a psychiatrist in private practice in Kenilworth. And as you can see, there's Bavi. She's in the bottom right-hand corner. And Bavi is going to be speaking to us from bump to belly and beyond, managing perinatal mental depression. But just before we begin with Bavi, I'd like to thank Chris and the Cape Town, the Pelvic Floor Foundation, for being the sponsor for this evening's presentation. And secondly, Bavi, I believe you have something to do with Marseilles. Would you tell us about Marseille?
Thank you, Peter. Thank you for giving me the chance to speak about it. I just want to, first of all, say it's a real pleasure and privilege to be here virtually and speak to all you guys because, I'm passionate about women's health and you guys are passionate about women's health. And it's so nice to speak in this forum. I'm stealing not even 5 minutes of your time. I just want to tell you about the Marseille Society. That's MARCE. Some of you may have heard of it. It's the International Society for Perinatal Mental Health. And next year in October, the international conference is coming to Cape Town for the first time. It's actually the first time we're having a conference in Africa because for the first time, our president is an African woman, Dr. Lavinia Lumu from Johannesburg. Some of you may know her. So it's really exciting. And if you can just sort of keep your eyes open and keep Marseille on your radar, because we'd really love to have all of you at the conference. And I think it's going to be a really fantastic conference. Peter, are we good to go? Can I start presenting?
Bavi, we're absolutely good to go. And I'd just like to thank you in advance. It's wonderful to have you. You've been here before. And we always enjoy what you have to say because maternal mental health is a huge problem. Unfortunately, at medical school, we didn't have anything to do with maternal mental health. And if you're an obstetrician, maternal mental health is integral to your daily chores. So it's wonderful to have you over here. Managing perinatal mental depression during pregnancy and afterwards, it's a wonderful and important topic, very worthy. We couldn't have a person more worthy than yourself to present. Just a short aside, I'm sorry that Professor Steve Jeffrey is not with us, but he will be with us next week, God willing. So, Bavi, without any further waste of time, from bump to belly and beyond, managing perinatal mental depression.
Okay. Thanks very much, and thank you for that kind introduction. I just want to tell you a little bit about the scope of the problem, which I think most of you working in women's health will know that perinatal mental health and depression is a problem. So worldwide, you're looking at about 10 to 15% of pregnant women and about 10 to 20% postnatally. But in South Africa, it's actually a whole lot higher. So in South Africa, we're looking as high as 40% of women, which is, it's a lot of women. So if you're working with women, you're definitely going to see this. And of these women, about 18% of pregnant women have suicidal ideation and behavior. And this is really a public health issue. It's not just a single person issue. It affects all women because perinatal depression doesn't just affect women, it affects their families as well. So the first thing in treating perinatal mental health is how do we make the diagnosis? And you can see I've got 3 blocks, the DSM-5 block, the EPDS, and the PHQ-9. You may be familiar with DSM-5, which is the Diagnostic and Statistical Manual. And in DSM-5, it's the same criteria for depression that we would use really at any time to make it. So the key features are depressed mood for most of the day, nearly every day for at least 2 weeks, or alternatively, anhedonia, which is lack of drive, lack of motivation, nearly every day for at least 2 weeks. But the DSM-5 criteria can be difficult to work with if you're not familiar with it, if you're not used to asking the questions. So we use standardized rating scales to make it easier. And the most common rating scale is the Edinburgh Postnatal Depression Scale, also known as the Edinburgh Depression Scale, the EDF. And this has been normed and validated in South Africa, and we use cutoff scores of more than 13. The problem with the scale, and I just want to check, I don't have a scale, but it's a 13-item scale. And some of those scores have to be reverse scored. So let's say somebody actually circles 1, you've got to give them a 3. So that can be difficult in a busy clinic to do a 13-item scale. It can also be difficult if you are using staff that maybe like an enrolled nurse or staff who are not very highly trained to do the maths. It might seem simple, but when you're doing this over and over, to think about, oh, they scored 1, I must actually make that a 3 and add it all up can be difficult. So they've come up with a 3-item EDS, which is just 3 questions that you have to ask, and you multiply that score by 10, and you get a cutoff of 10. Even easier, you can now get this as on your cell phone. You can get it as an app. You can Google it, and the scale comes up, and you can put it in, or you can get the patients to do it on their phone, or you can do it in the waiting room, and that will score it for you. Another scale that you might find useful is the PHQ-9, the Patient Health Questionnaire 9. And the Patient Health Questionnaire 9 is something you may already be familiar with because we use it throughout medicine. It is a 9-item score, which is very easy to use because you just sum the answers. And again, the PHQ-9 comes in electronic format, and it'll add it up for you. Just as an aside, there's this really nice site called MD Calc, capital M, capital D, CALC, like MD Calculator, but Calc for short. And you can get these scales and many, many other scales, not just psychiatric rating scales, other scales on the site, and it's free. And you can just use it on your cell phone or an iPad. You put in the score and it calculates it for you, and it also interprets what the score is. So for example, on the PHQ-9, a score of more than 9 says to you, okay, this is now moderate depression, we need medication. Or this is a severe depression, needs to be escalated, needs to see a psychiatrist. If we look at the 3-item EPDS, these are the 3 things that came through. I've blamed myself unnecessarily when things went wrong. I have been anxious or worried for no good reason. I felt scared or panicky for no good reason. And this is validated, as I said. These are the questions to ask, and you multiply it by 10. So if they're answering 1 question, for example, I've been anxious or worried for no good reason, it's an indication to you that you need to look further. The EDS is a screening tool. It's not a diagnostic tool. It's not going to say this is definitely depression. It tells you, go and look further. The PHQ-9, on the other hand, is screening, but it can really help you diagnose depression. That's what the pencil and paper version looks like. And the pencil and paper version is quite nice because you can see it's got a shaded area. Does my cursor show? Yeah, you can see there's that shaded area.
Yeah, yes.
Then question 9 is shaded. And any 4 ticks in the shaded area will say, all right, we've got to flag this patient must be investigated further. Or any tick in this area, thoughts you would be better off dead or of hurting yourself in some way. If the patient endorses any thoughts, you need to investigate further. And I think it's just useful to have these standardized screening tools because it helps us figure out what questions to ask. And in psychiatry, asking the right question, in medicine, asking the right question is really important. And it can really help save time because you can get the patient to do this in the waiting room and then they come in and all you have to do is look at the scoring. But what are some of the barriers to screening? Why are we not screening regularly? Well, time is a barrier. Our consultation times are getting shorter and shorter, and we're expected to do more and more in every consultation. Um, I don't know about obstetrics and gynecology, but certainly in psychiatry, medical aides are pushing us to do less and less time
More.
consultation. I'm sure you get the same thing.
No, we do. It's absolutely.
And I think the paperwork burden that we have is just immense. So, I'm saying to you, screen, and you're probably thinking, oh, where do I have the time to do this? So that is a barrier. We recognize it, which is why we're saying try and get the women who come into your practice to do it in the waiting room. Follow-up is also a problem. Peter and I were just talking beforehand about how there isn't a full-time psychiatrist at his hospital, which may be the case for many of you. So if you see someone and they've screened positive or you think they're depressed, what do you do? I mean, where do you send them to? Do you have the capacity to actually manage the patient themselves? And then there is a question of, is treatment available? Are there psychologists that you can refer to? Are there psychiatrists? Do you feel comfortable prescribing medication? And I'm hoping that by the end of this talk, we will have addressed some of these problems and you'll feel that you have more capacity to actually see patients with depression. So you've screened the patient and you found they're depressed. How do we manage patients? So psychotherapy is kind of the first line gold standard for treatment. And any form of therapy has its benefits. Even supportive psychotherapy, which is a fancy way of saying that to do what we do anyway, to be kind and warm and affirming to patients. I mean, all of us do psychotherapy every single day because that's what we do with our patients. But the most data is actually for cognitive behavior therapy or interpersonal psychotherapy. You also want to do socialized support. You want to get the family mobilized, especially the partner. Bring in the partner, talk to the partner, get the partner to understand that the woman is not bad, she's ill, she's sad, she needs to be nurtured and cherished. And get the partner to understand that they can play a role by really looking at doing what their spouse wants or what their partner wants. So often people want to give support and they're like, oh, I'll come in and I'll wash the dishes or I'll look after baby if this is a postnatal mom. And the mother doesn't actually want that. So you want to help the family give the support that the woman needs. Baby clinics are really a great source of support. When we still had postnatal depression in South Africa, sadly, postnatal depression had to close because of lack of funding. We trained nurses in baby clinics throughout the private and the public sector. So we had a really well-trained force of nursing staff, many of whom are still there. And there are other initiatives like from SADAG to train nurses in the clinics. But a baby clinic is a space where mothers go to often. And very often, mothers who have depression or anxiety are very worried about things to do with the baby. Are they feeding enough? Are they sleeping enough? The poo looks funny. What must I do? All these weird and wonderful questions that a baby clinic sister can really answer and can help support. And if you link a mother with a supportive baby clinic, often she meets other mothers in the clinic and they can provide support for her. And then the third pillar is medication, and I will get to medication in a while. So I said psychotherapy, it should be first line, and it should always be offered to all patients. The problem is the moderately to severely ill patient. So that patient who's scoring 10, 15, 20 on the PHQ-9, that patient is not going to get fully better on psychotherapy because by the time you're moderately to severely ill, your brain chemistry, your brain architecture is deranged to the point where psychotherapy alone is not going to shift it. You actually need medication in that patient to make the shift so that they can engage with psychotherapy and they can become properly well. Access is an issue. We don't all have psychologists in our areas. The psychologists may be full. You may not be able, even in Cape Town, we have so many psychologists. But to find a psychologist in your area to see your patient is actually quite difficult because most of them, or certainly people who have experience in working with mums in the perinatal period, are very often full. And then there's cost. Medical aids only pay for 15 sessions, split between psychiatry and psychology. 15 sessions is not a lot if you think about it. And people often can't afford to pay out of pocket. So these are the things that can limit our access to psychotherapy. But if you can refer to psychotherapy, then you should. So moving on to medication, and that picture of the mum with a handful of medication is actually not what we want to do in pregnancy. We want to do as little meds as possible. But if you need meds, we should give meds. So the moderate to severe depressions, where the PHQ is 10 and above, if there's no psychotherapy available, if you're sitting in a situation, you may be working in a government clinic where the psychologists are not available or they're full, or you're working in a setting where there's no psychotherapy, you should start medication because you have to treat this mother. You can't just leave her to get better on her own. If psychotherapy alone has failed, if someone's had 8 to 12 sessions of psychotherapy and they're not shifting at all, you should consider medication. Or if somebody in the past has had a good response to medication, the likelihood is that they will get better with medication again, and you should consider it. And the third one is suicidal ideation. I mean, we talked about the rates of suicidal ideation in mothers. Peter talked about the risks of maternal mental health problems. Many of you will know the Saving Mothers report and how suicide comes up as a cause of maternal death. So suicide is a real problem in women who are pregnant and postnatal. And, it's important to address this. And generally, suicidal ideation is a marker of a more severe depression. So it's really important that if there is suicidal ideation, to at least consider medication. And if we look at psychiatric medication in pregnancy, the problem is not that we don't have medication, we have medication. The problem is that we actually have too much information. I did a PubMed search, just 2015, and I just put in pregnancy antidepressants. And in the last 10 years, there are more than 200 articles. I mean, who of us has the time to go through all of that? If you look at review articles, more than 50 articles come up. And that is just with pregnancy antidepressant keywords. If we put in postnatal, if we put in other keywords, we're going to get more. So the thing is, you really have to pass out the literature. And the thing with the literature is that there's a huge focus on fetal and infant effects, but there's not a lot of consideration about maternal effects or maternal distress. And it's important for us to look at maternal distress because depression is horrible. We wouldn't say to the epileptic woman, oh, just have your seizures and hang on. Just pull yourself together and manage the seizures without medication because we don't want to expose the baby. So why do we say to women who are depressed and anxious, just pull yourself towards yourself and carry on? It's not right. We should be offering medication to women who meet the criteria for medication. So the challenge, if we look at antidepressants in pregnancy and lactation, is to integrate all the available data into a strategy for your patient. So strategies need to be individualized for the patient sitting in front of you. And this is called a risk-benefit analysis. And many of you will have heard about risk-benefits analysis, where we look at the risk versus benefits of medication to the mother and the unborn child. So we look at risks of medication to the mother-unborn child dyad versus benefits of medication to the mother and unborn child dyad. We must also look at the risk of mental illness to the mother, to the unborn child, and to the wider family. Because mental illness poses a clear risk to women. The longer the duration of untreated mental illness, mental illness is a brain on fire. It's an inflammatory process in the brain. And just like with other inflammatory processes, you want to stop these as soon as possible because they go on and they create damage to the underlying tissue. A mental illness, depression is an inflammatory process. If we don't treat it, the likelihood of it perpetuating, the likelihood of it coming back becomes higher. Depression is also a risk for poor outcomes like dementia, cardiometabolic disease, and obesity. And there's this reciprocal relationship between cardiometabolic disease and depression. So it's important to treat this for the woman. For the unborn child, depression in the mother has physical risks to the baby in terms of risks for pregnancy. There is a small but definitely increased risk for things like small for gestational age and pregnancy-induced hypertension and also preterm labor. Years ago, I was involved in a study called a PASS study. Some of you may have heard of it. It was prenatal alcohol, SIDS, and stillbirth, and it was a big multi-center NIH study. And one of the outcomes that we looked at was preterm birth. And we all obviously had a mental health arm. We were looking not just at substance use, we were looking at depression. And over the course of the study, which ran over 5 years, the rates of preterm birth in the study participants dropped and dropped significantly. And this was not an interventional study. This was a purely observational study. And they looked at multiple reasons for this. And the only thing that they could come up with was that study participants were having frequent extra antenatal visits as part of their study visits. And each time they were seen, they were being asked about their mental health, they were being asked about their drinking, they were being asked about how they were doing, and they were being given care. And they postulated that because they were given care and support, this was in some way modulating their anxiety and depression, and it was modulating the HPA axis, and it was decreasing the risk of preterm birth. So mental illness has significant effects, and we're only starting to untangle what are these physical effects of mental illness and starting to understand that it's not just the psychological effects, but the physical effects as well. But the psychological effects to the baby and to the wider family are significant. A mother who is depressed can't mother a child. I mean, think about it, for those of you who have kids or have been involved with children, when you've had a bad day, when you come home and you're tired and miserable, you struggle to be present for your children. All of us have experienced that. Now, can you imagine if you're depressed? Day in, day out, you're not going to be present for a child. That has a huge negative effect on a child and on the wider family as well. Mothers, it's not only just the baby. There may be a toddler, there may be an older child, there's maybe a partner. There's a wider family, and the mother who's mentally ill can't be present for her wider family, and that puts them at risk of mental illness. So if we look at medication, what do we need to know? We need to know about teratogenicity. We need to know about the risk of untreated illness. We need to know about long-term outcomes, and we need to know about what else we can do other than medication. So in terms of teratogenicity, and many of you will know this, is with medication, there's a big concern around cardiac abnormalities, especially with paroxetine. But very reassuringly, several really large meta-analyses, more than hundreds of thousands of women, show no increased risk with the SSRIs and the SNRIs. So the SSRIs and the SNRIs are our go-to during pregnancy and can be safely used during pregnancy and lactation. Because there's
Bavi,
also, yeah.
Bavi, sorry, can I just come in over here?
Yeah.
For the benefit of people like me, which examples of SSRIs and SNRIs do you have? Can you give me some names?
SSRIs would be things like fluoxetine, which is Prozac,
Fluoxetine, yeah.
Muzak, Lorien, and then sertraline, which is Zoloft, Serdep, Serlife, Sertra. Those are the two most common ones that we use during pregnancy. And then the NRIs would be things like venlafaxine, which is Venlaw, or duloxetine, which is like Simgen or Yelate.
Okay, thank you.
And there's no pattern of abnormalities that are suggestive of teratogenicity. So we're really comfortable using the SSRIs in pregnancy. And I hope that you will be comfortable as well.
Yeah.
If we look at persistent pulmonary hypertension of a newborn, and it just as an aside, it's so nice giving this talk to this audience because then I don't have to explain what persistent pulmonary hypertension is.
I hope so.
So you can see that there is a small increased, okay, and this comes from a very large cohort of women. And the odds ratio for SSRI exposure was 1.28, and non-SSRI was 1.14. But I want to draw you to the odds ratio for delivery by cesarean section, which is 3.2. So a lot of people say, oh, stop the SSRI in the third trimester because you're not going to have a risk of persistent pulmonary hypertension. So first of all, if you stop the SSRI in the third trimester, it's not clear that you will decrease the risk. The second thing is that you increase your risk of relapse of the mental illness by between 60 and 80%.
Wow.
And the third thing is that, persistent pulmonary hypertension is a rare condition. So even if that odds ratio goes up, you're still getting an increased incidence of a rare condition, although it's devastating when it happens. And nobody is saying don't do cesarean sections. I mean, you guys are the experts in cesarean sections. You obviously have your reasons for doing it. But by the same token, if somebody's on an SSRI, they're on an SSRI for a reason. Don't just stop it. Chat to the person who actually prescribed it to understand what is the risk of stopping it. People often worry about neonatal adaptation syndrome, which you can see has got all these different characteristics. In babies who are exposed to SSRIs, it's most often mild. The thing is, it's modulated by so many factors. It's not clear, is this the SSRI? Is it the mother's distress? Is it a male baby? Are they formula fed? What's going on? But in most cases, these babies can be supportively managed. The important thing is not to tell the mother, oh, it's because of your medication, because she can't change what happened, and that just blames her. And I've seen so many mothers devastated by being told it's because of their medication. It might be the medication, but it might be a host of other factors, and we can't really say what it is. If we look at neurodevelopment, for IQ, it's clear that it's maternal depression. So untreated maternal depression drops children's IQs, which is a really good argument for treating maternal depression. If we look at internalizing versus externalizing behaviors, internalizing behaviors are things like depression and anxiety, where you turn it inward, and externalizing behaviors are things like delinquency, conduct disorders. And here the data is mixed. It's not clear if it's due to antidepressants, but it's probably because of maternal depression. And in terms of motor development, there are statistical delays in motor development, but this doesn't seem to be clinically relevant. Autism risk, it's a hot topic. If you give an SSRI, do you increase autism risk? And the evidence is really, really conflicting because we only have 3 studies, and these studies are retrospective case studies, but they do show that even when you adjust for maternal depression, you might have an increased autism risk. So what we actually need is prospective studies. And the current recommendation is that women who are low risk for autism should be treated with antidepressants. But in women with high risk for autism, you want to carefully consider it, and you should ideally have a psychiatrist make the decision and really counsel the mother about what her risk is with an antidepressant. And the question is it the drug or is it the effect of a depression? And the problem is that we don't have good control groups because mothers who are on medication are more severely depressed, more likely to smoke, more likely to use alcohol or substances, and have poor they're just a whole different group of women. And all these things have synergistic effects. How do you untangle alcohol use and smoking from depression? I mean, it's impossible. So it's likely that the more severely ill mother is just different and is biologically different to the mother who's less severely depressed. I talked about the effects of untreated perinatal mental illness, and it's important to understand that untreated perinatal mental illness is an important risk for poor obstetric outcomes. We must consider that depression and anxiety have suffering. Women with depression suffer, and I think it's important to remind ourselves of that. Because women with depression will often say, don't worry about me, treat the baby, but we have to worry about mum too. And we have to remember that women with preconceptual illness and antenatal illness are at high risk for postnatal illness, which after malnutrition is the single biggest risk factor for poor child development. And depression and anxiety is associated with marital conflict and ending of marriages and marital discord. So it's really important that we treat depression. I just want to run through the other antidepressants for you quickly. Bupropion, which is Wellbutrin, has very reassuring safety data. Vortioxetine, which is Brintalex, is only got a case series, so we tend to avoid Brintalex during pregnancy. Agomelatine, which is Valdoxane, very little data, so again, best avoided. Mirtazapine, which is Remeron or Mirteron. There's no increased risk of malformation, so Mirteron can be used during pregnancy, but there is some safety data in lactation. And trazodone, which very often gets used for women who can't sleep, trazodone is just available in this country as trazodone. The accumulated data shows that there's no risk of teratogenicity. So what agent do we choose? So we generally go with the SSRIs as the first line, with the caveat being that you choose what the patient has responded to in the past. So if they didn't respond to an SSRI, but responded to venlafaxine, that's what you would choose, because there's no point in giving a medication that they're not going to respond to. Pick what works. If you're not sure, then send the patient back to their psychiatrist and let the psychiatrist work with you to make a decision. Let's say the patient falls pregnant on medication. Don't stop the medication because you already have an exposure at that time point. And the risk of relapse is 60 to 80%. And again, talk to the person who prescribed the medication. Prescribing postnatally is very similar to prescribing in pregnancy. And again, I want to say that stopping increases your risk of relapse. And if you have had antenatal exposure, the exposure via breast milk is much, much less. So there's no reason not to allow the mother to breastfeed. And this is just for your interest, because I doubt people will ever get zuranolone in this country. But zuranolone is a neuroactive steroid. It works at GABA receptors. It's actually an allopregnanolone. You know, allopregnanolone is a progestogen metabolite. It's an allopregnanolone derivative. And zuranolone separates from placebo at day 3. It's commercially available in the States. I mean, it's really amazing because to get an antidepressant that separates and shows efficacy at day 3, because most antidepressants only usually separate at day 10 to 14. The problem with zuranolone is we don't know anything about lactation, but it's heralding a new class of antidepressants for use during pregnancy, but also for use in the general population. So for us as psychiatrists, this is really exciting. I want to talk a little bit about bipolar mood disorder because we see bipolar mood disorders. And the thing is that there's this big overlap between the perinatal period and bipolar mood disorder because the reproductive years are the time for peak onset of bipolar mood disorder. The hormonal, the physical changes of pregnancy, the stress of childbirth and becoming parents, and the lack of sleep can all precipitate a bipolar. And many women present during pregnancy or postnatally for the first time with a bipolar illness. And bipolar mood disorder is a serious risk factor for perinatal suicide, postpartum psychosis, and infanticide. You've probably seen women with bipolar, and you may not have known it. So the thing is, should we incorporate screening for bipolar and bipolar spectrum disorders? And the thing is, if we don't screen for hypomania, this may result in the misidentification of both postpartum and antepartum mental illness. Because hypomania, elevated mood, euphoric mood, is really the key feature of a bipolar disorder. And the treatment of bipolar is very different from depression. If you give an unopposed antidepressant in bipolar, you make it worse. So you have to give a mood stabilizer. And you can screen using the mood disorders questionnaire. It's accepted, it's validated. The problem is it looks like that. They say 5 items, but it's 5 items with lots of questions. So it takes time. And in a busy obstetric practice, you actually don't have the time to do that. I'm saying you don't have the time. I'm assuming you don't have the time, but I mean, in a busy psychiatric practice, we find it difficult to do this. So I can imagine with all the other stuff you have to do, it would be difficult to do this questionnaire. So again, the limitations to screening are time, having staff to do it, and follow-up care. So it might be useful to have a 1-item question that you can ask to screen women for hypomania. And the question that is generally accepted is, have you ever had a discrete period of time when you were far more happier than normal or far more irritable than normal? And in the same time, you needed less sleep. Others noticed you were more talkative, you felt your thoughts were racing, or you did things out of character for you, like gambling, shopping, or engaging in risky sexual behavior? Now, that is a single question that you can use to screen. And if someone does screen positive, if you have a concern around bipolar, it is important to refer. So the take-home message for bipolar is that it's much more common than previously thought. It has significant adverse outcomes for mother and child, and we should try and screen patients wherever possible. I just want to talk a little bit about lithium during pregnancy, because choosing whether to maintain or discontinue lithium is challenging. And certainly, when I was at medical school, we were taught, and even actually when I was doing my registrar training, we were taught that you should not use lithium at all during pregnancy because of the risk of Epstein's anomaly. The thing is that lithium definitely increases the risk of Epstein's anomaly, but far less than was previously thought. We were taught that the risk of Epstein's anomaly was 3 to 5%. But the latest studies are saying that the risk of Epstein's anomaly is 0.6% as opposed to 0.18%. So it's still a higher risk, but it's a much lower risk. And if you use lamotrigine, which is Epitech or other mood stabilizer, the results are the same. So Epitech is probably your mood stabilizer of choice, except in pregnancy, nothing works like lithium. For women who have bipolar mood disorders, lithium is the gold standard in pregnancy. And it really is, we use it prophylactically for preventing postpartum psychosis in women who've had a previous history or women who have bipolar mood disorder. But lithium in pregnancy is tricky because you've got to monitor the levels. As you know, fluid volume changes during pregnancy, so levels drop, and then you have to gradually increase. And then the woman gives birth and her fluid levels decrease, so lithium levels go up. So it has to be co-managed between the psychiatrist and the obstetrician. Other effects of lithium, and this is a big Swedish register study. And basically, sorry, I seem to have missed a slide, but other effects can include weight gain, but they didn't seem to find other effects were a major problem. But if you look at previous studies, again, difficult to distinguish the effects from the effects of the underlying disorder. But after adjusting for confounders, lithium itself doesn't seem to cause a risk of preeclampsia, placental abruption, growth restriction, or preterm birth. But bipolar mood disorder is clearly associated with worse pregnancy outcomes. And bipolar disorder in women, whether treated or not, is associated with worse outcomes. So it seems to be the bipolar that's the problem, not necessarily the treatment. Just to tell you again about lithium in pregnancy and labor, as I said, close monitoring. So in the monthly in the first trimester, 2 weekly from 28 weeks and weekly from 32 weeks. And this poses a challenge in terms of funding for us because the patient will have used up all their benefits. So we have to wiggle a little bit, but we do need to see these patients. And you need close follow-up. You stop lithium the day before cesarean section or at the onset of labor. Women with bipolar, whether they're on lithium or not, should be delivering in hospital with an IV line in place, good analgesia. The thing with labor and delivery, as you know better than I do, is that the pain of delivery can cause women to dissociate. And the pain of delivery in a woman with an unstable bipolar can actually cause her to have psychotic symptoms. So it's really important that she delivers in hospital where you have the capacity to manage that, to give her sedation, to do what is needed for her. When these women, and unfortunately, the bipolar patients always seem to want to deliver at home. And you have to be quite firm with them. If they're on lithium, they absolutely have to deliver in hospital. And you have to do a lithium level post-delivery, and you restart in conjunction with the psychiatrist. And again, this is just for your information, something fun to end off the talk. We all know about oxytocin. For us as psychiatrists, oxytocin is the hormone of love, and that is what oxytocin looks like. I know you give oxytocin for very different reasons, but oxytocin enhances bonding. It's a pro-social hormone and plays an important role in childbirth and maternal behavior. It's the cuddle hormone. It's the social affiliation hormone. And oxytocin increases in response to stress, but also in response to warm social or physical contact. So when a mother is holding her baby, when you are with your loved ones, when you're cuddling your pet, your oxytocin levels will go up. But is oxytocin related to depression? Is oxytocin modulating depression in some ways? And the question that led us to wonder about oxytocin is in children of depressed mothers, is some of the behaviors related to lower oxytocin levels. And what we see is that in women with depression, are oxytocin levels lower? Yes, they are. So oxytocin is lower in mothers with depression and in their children. And is this a direct physical effect of depression? Or is this because the mothers are not as engaging, they're not present, they may be not bonding, there's less cuddling? It's really, really difficult to say. But what we also see if we do genetic studies is that depressed mothers and their children are 3 times more likely to have than the control group to have the GG homozygous variant of the oxytocin receptor. And this is a less active variant of the receptor. So maybe genetically, these are people who need more oxytocin, and that predisposes them to depression. And they're not getting the oxytocin, which is why they become depressed. And then you get this vicious cycle where they need more oxytocin, but they're not getting it, and it just goes round and round. So should we give mothers oxytocin to treat depression? We're not there yet, but there have been a handful of studies that looked at the effect of oxytocin. And you know, for oxytocin to reach the brain, to cross the blood-brain barrier, it has to be intranasal oxytocin. IV oxytocin or IM oxytocin will not cross the blood-brain barrier. And the interesting thing is that it doesn't make mothers happier, but it does improve their perception of the relationship with their baby. And they do become more protective of their children. So maybe oxytocin in the future will have a role at facilitating bonding in mothers with postnatal depression who struggle to bond with their babies. And there are compounds of oxytocin currently being trialed as antidepressants, but as yet nothing that has reached phase 3 trials. So that's just something to pique your interest going forward. And I just want to conclude by saying that more and more we learn that antidepressants are relatively safe during pregnancy. So please do treat with antidepressants if needed. Bipolar mood disorder gives us many challenges in treating them, but there is treatment available, and that we can use lithium during labor and in the postnatal period. And we may be getting novel therapeutic agents, some already available in other countries. And these really focus on hormones. And I think hormones are going to be a new area of interest in development of therapeutic agents. So I just want to thank you all for listening, and I'm not sure if there are any questions.
Bavi, it's been a wonderful, wonderful presentation, very short and to the point as always. May I ask 1 or 2 questions at this point? We've got patients that are on long-term oxytocin. There's one in the ward at the moment who's been on oxytocin for almost a month. She's now 28 weeks. And I mean, not on oxytocin, on oxytocin antagonists. It's called Tractocil. Would you, from what you've said in the last 10 slides regarding oxytocin, think that on oxytocin antagonists, which is Tractocil as a drip, would cause depression or not?
You know, it depends if Tractocil crosses the blood-brain barrier, which I don't know. If it does cross the blood-brain barrier, you may have problems with increased risk of depression. But if it doesn't, then it should be fine. Is Tractocil a fairly large molecule? Is it a protein?
I'm terribly sorry. I don't know the molecular composition of Tractocil. It's widely used for premature labor, particularly in twins, and it's a wonderful drug. The only side effect, as far as I know, apart from constipation, is poverty, because it's very expensive. Whether or not it crosses the blood-brain barrier, I'm not sure. You know, in the olden days, we used to use oxytocin given parenterally, not as a drip, but also tablets and things. They've been withdrawn, so we don't use those. But the tractor seal effects, I'm not sure if they do cross the blood-brain barrier, but I guess that's the answer. If it does, it theoretically can cause depression. Now, another question over here that's just come up. Thank you for allowing us to use these things, Muzak, Prozac. Which antidepressants or which medications are actually contraindicated that we should not use during pregnancy and lactation? Are there any which we should avoid at all costs?
So in terms of antidepressants, for vortioxetine, which is Brintellix, there's no data for Brintellix at all. So Brintellix is actually contraindicated during pregnancy, except in the very rare instance where the mother has not responded to anything except Brintellix. And there you would need to make that decision with the psychiatrist. It's a difficult decision to make. Paroxetine, which is things like Paxil or Arapax, is not contraindicated, but paroxetine was the original drug where they thought there was cardiac abnormalities. So
Yeah.
because of that, I mean, the latest data doesn't show that, but because paroxetine was the drug that was associated with cardiac abnormalities, the recommendation is don't use paroxetine if you can help it. And
Okay.
that I think that's more to protect us from a medical legal point of view. Similarly, for fluvoxamine, which is like Luvox or Favarin, which hardly anybody uses, there's just very little data on Favarin. So probably best avoided unless the person really, really needs Favarin. And in fact, I think you can't even get it in this country anymore. We're having problems with supply. In terms of the mood stabilizers, as you know, sodium valproate, which is drugs like Epilim and Navalpro, is completely contraindicated in women and more recently men of reproductive age because it is so highly teratogenic and it has such neurodevelopmental problems. So, that's the one absolutely contraindicated. And actually, if you starting somebody of reproductive age on sodium valproate, they have to sign a contract and agree to go on contraception. So it's quite a thing.
It's a bit like the retinoids.
Yeah.
Bavi, if we often see, at least I often see, pregnant women that are very anxious and they have anxiety disorders, mild ones in pregnancy for various reasons. What would you say is safe for the medication for these women with mild anxious or anxiety disorders in pregnancy?
So if it's a mild disorder and you can access psychotherapy, I would do psychotherapy first. But in
Yeah,
terms of medication, I would start with an SSRI, so something like fluoxetine or sertraline.
that's Muzak or
Yeah,
Prozac.
yeah. Muzak or Prozac or Zoloft or Serdep.
Okay, SERDEP, yeah. Okay, that's great. Now, you actually work opposite Kahiso, which is how would you describe Kahiso? A clinic for
It's a
people
clinic.
with psychiatric, a clinic. Do you use nowadays in 2025 ECT in these clinics for women and men with women in this case with depression or not?
I'm glad you brought it up. I'm really glad you brought it up because actually ECT is really, really effective for depression during pregnancy and postnatal depression. We don't use it often because we thankfully don't see women that ill. But if you have somebody who's got a severe postnatal depression, who is psychotic, ECT can get them better very quickly. If you have somebody who's got a severe depression, who's not eating, where their self-care is very poor, where you're worried about their physical health, ECT can also get them better very quickly. During pregnancy, in similar circumstances, ECT is effective. The problem is that in order to do the ECT on someone who's pregnant, you actually should be doing it in labor ward with fetal monitoring. And because certainly in the private sector, most general hospitals don't have ECT machines, and most general hospitals don't have psychiatrists working there. To do it practically is difficult. When I worked at Grooteskier, we did it once or twice for women who were really severely ill, but I've not ever done ECT on a pregnant woman in the public sector. And then
Okay.
if I can just mention ketamine. A lot of you will have heard about
Yeah.
ketamine. Ketamine is contraindicated during pregnancy, so we can't use it at all during pregnancy. But in the postnatal period for severe postnatal depressions, ketamine can be used, but for that day of ketamine, the mother should not breastfeed. She should pump and discard her breast milk.
Okay, thank you very much. I'll never forget ECT. I've always thought about it because when I was a student in Pretoria at a place called Grundakkies, they had a registrar, a psychiatric registrar, used to use ECT on himself during lunch hour. He used to connect. No, I'll never forget it. And from that time onwards, I've always had a soft spot for ECT. So, Bavi, it's been wonderful. And thank you for bringing up all these things like the use of oxytocin antagonists you've mentioned, the contraindications and the indications which you use, and also, of course, then ECT and anxiety disorders in women, what to use. It's been wonderful having you. I'd like to, on behalf of the Pelvic Floor Foundation, thank you very much indeed. And we hope in the future to be able to once again tap into your vast supply of experience and knowledge. And also I look forward to, just tell us again, what is that, the Psychiatric Congress that's for October 2026? It's called Marseille.
It's a Marseille conference, MARCE. Notices will go out, and we would really welcome all of you there. We want people from as many disciplines as possible. If you are interested in working with pregnant women and women in the postnatal period, then Marseille is a conference for you. And it's interesting, it's exciting, and like I said, it's the first time on the African continent. So if I may, when we send our conference,
you may. Please,
I will send it to you, and if you can distribute it among your society, that would really be great.
Bavi, I will do it with the greatest of pleasure. Chris is our administrator, and he certainly will. And while we have everybody, all the delegates, hundreds of them online, just to remind you that in 6 weeks' time, we have the FIGO Congress at the CTICC in Cape Town, right next door to our hospital. And that is an obstetrics and gynecology congress. Registrations are still open. We still have a few spots left. So if you don't mind, register for that. And that's a wonderful premium worldwide congress. Thank you, Bavi. And safe home. All the very best. And thank you for your time. Bye-bye.
Bye-bye.
Thank you so much. Bye-bye.